Welcome everybody, good morning. This is the Palliative Care Summit sponsored by the Department of Health, JABSM, and Kokua. We're joined by potentially over 100 colleagues from around the state and even some from the mainland, which is really exciting for us. We were hoping that we were going to be able to meet all of you in person in a big room, share a lot of discussion, but well, you know the drill. But despite that, we hope that this summit will spark interest, curiosity, and commitment because we are on a mission to increase and improve palliative care in our community. Today we have, some housekeeping to start. First of all, I assume y'all know where the bathrooms are. We have a master of Zoom at Control Central, and that is Crystal Costa. And she is aided by her trusty sidekick, Marcus Fago. Their job is to help us keep things running smoothly and to keep us on a tight agenda. You can message them through the chat if you run into any problems. You will be muted during this summit because, of course, with over 100 people, it would be quite a cacophony if everybody was unmuted. You may hear a ring during a presentation. Marcus, can you do the ring? And this sound, when we hear it, is a reminder to the speakers that they have. There you go. Can you do it again? Hopefully, people have better hearing than me. I encourage you to use it as much as you like, because we will be monitoring and collating, curating what comes in over the chat. Dr. Buenconsejo-Lum and Dr. Takeshi Uemura are going to be taking all of that information and putting it into a Jamboard, which will be the focus of a panel discussion that we'll have at the end of the conference. We need your feedback about the content and the form of this meeting as well. So please do complete the survey after the summit is concluded. We also will be using polling as an additional way to capture your feedback. And so we thought we'd practice, and here's our first poll.
Marcus, can you pull up the poll?
While they're working on that, I'd like to ask that you please consider joining this effort because we are in a very special time in the state of Hawaii, where there is growing interest and commitment to establishing more palliative care, for defining palliative care and setting quality standards, and to really move these efforts forward. But it's going to be a big, heavy lift. And so everybody who's interested, please volunteer. We will have a way for you to sign up. And of course, we are more than happy to nag you as well. Do we have the no poll?
Marcus, I need you to pull up the poll.
Okay, I'd like to tell you a little bit about the organizing team and how we came to be here today. And underneath some of those windows are pictures of the team that have been working for several months, hours and hours every week on this. Most of us have been working for quite a while in palliative care. In our backgrounds, we've designed and built palliative care programs, which currently are providing care for our community members in their homes, their hospitals, and clinics. We directly provide palliative medical care. We lead interdisciplinary teams. We provide hospice care. We teach palliative care knowledge and skills, not only in Hawaii, but on the mainland and internationally. We offer counsel and advice to decision makers, and we continue to work to figure out ways to expand palliative care for our community because we see firsthand how valuable this care is to patients, their families, our providers, and the healthcare system overall. Do we have a poll yet?
It's already done.
Oh, it's
being
done.
shared.
Okay, did we do the second poll?
What does your screen show you?
Sorry, my screen is hidden. Okay, so what we have, oops, it disappeared from my screen. 40% of people registered today are physicians, 16% nurses, an additional 7% APRNs, 7% social workers. Sorry. Check. Oh, chaplaincy administrators and others. Great. Okay, I don't see the second screen, but if you're like me, you're not wearing pants. Last fall, two things happened which were pretty significant. The first being that MedQuest expressed a strong interest in developing a palliative care benefit for its members. Also at that time, mostly through a lot of the work that we were doing with the Department of Health, leaders there came up with the idea of a statewide summit on palliative care, and that would be a great way for us to move the work forward. So when the Department of Health decided that they needed help to organize the summit, they turned to those of us on this organizing team to help them get that done. We've organized this summit to stimulate thinking and discussion around three main topics. Number one, what is the current state of palliative care in Hawaii? Number two, what would an ideal state of palliative care in Hawaii look like? And number three, what issues, gaps, or areas should we focus on in our next steps to move us toward an ideal state? We want feedback from you around two major concepts or issues that we think are foundational to our ability to move forward strongly to build more palliative care in Hawaii. The first is we would like eventually to develop a consensus about the definition that we feel is most appropriate to apply to our work here in Hawaii. The team has got very strong opinions about a definition that we would recommend as most appropriate, and we would like your feedback and discussion about that. You should have gotten that definition in your last email about this summit. We also want feedback about what minimal standards or core elements should be included in any program which calls itself palliative care. We found that when people say palliative care, they mean a lot of different things. It's time for us to mature and to get consensus on what it is exactly we mean when we say palliative care. Again, we have some recommendations based on a review of a number of documents, experiences of other states, and our own experiences as well. So again, welcome. Let's get started, because as you can see, our agenda is pretty packed. Can you put the agenda slide up there? Agenda? No. Okay. Yeah, so it's pretty packed for 2 hours. I often find that to understand where we are, it's helpful to look at where we've been. And where we have been in Hawaii is nothing short of amazing. But here's where I must beg your forgiveness, because while we tried our best to log all of the wonderful innovations, programs, services, activities in our history, we undoubtedly missed a few things. So please help us complete this timeline by telling us when we missed something. You can do this via the chat. All of these events are remarkable. There's probably amazing stories behind these events. Someday I will write it up. But in the interest of time, I'm just gonna blaze through them, okay? So in the late 80s, this was a really active time, much to my amazement. At Queens Medical Center, a nurse-run pain management team was founded by the legendary Hab Osterlin. In 2004, under the leadership of Dr. Daniel Fischberg, this team evolved into the interdisciplinary palliative care team that we know and respect today. Around the same time, in the 80s, there was an innovative little program in Kona. Most of us probably didn't know that. Under the leadership of two people who probably were the first certified palliative care physicians in the state, Robin Cito and Steve Denzer. They called their program Care Beyond Cure, and I believe it was based in long-term care. These two pioneers also held some of the first palliative care conferences with notable speakers like the Venerable Dr. Ira Byock. Significantly, also during this time, the governor convened a blue ribbon panel on death and dying. This, together with a grant from the Robert Wood Johnson Foundation, led to the establishment of Kokua Mau. The early years of the 21st century saw Hawaii's first home-based palliative care program established at Kaiser Permanente. This was built through a randomized controlled trial held at 2 centers and led by Dr. Richard Brumley. This study was a landmark study and led to a publication in 2007. That article continues to be cited hundreds of times every year and is often used as evidence to argue for the value and sustainability of palliative care. I think I am really going to jump all the way through and just highlight a few things without going through all of it. 2012, University Health Alliance takes the very brave and audacious step of offering open access hospice or concurrent care to its members. That same year, Queens Medical Center becomes the first in the state and among the first in the nation to receive Joint Commission certification in advanced palliative care. Other hospitals have followed. At Straub, an ACP clinic was established and the first hospice inpatient unit on a neighbor island opened in Hilo. In 2013, HMSA launched a statewide effort to improve advanced care planning by making available video decision aids created by Doctors Angela Fernandes and Aretha Delight Davis of Massachusetts General. That was a banner year because it was the same year that supportive care was launched, and that was a game changer. What changed the landscape, I think, for good was when HMSA made supportive care a benefit to its commercial plans in 2018 and a benefit to its Medicare Advantage plan in 2019. Jump forward to today, there's a significant amount of innovation going on right now. Much of it is coming out of our hospice partner companies, Bristol Hospice, Islands, Navian, the VA, Hawaii Care Choices is in a partnership with Johanna Healthcare, and we're going to hear about some of those programs today. We've come a long way, right? And we have a lot more to do, so let's get on with it. Before I turn over the mic to our moderator and presenter for today, Dr. Daniel Fischberg, I'd like to share a patient story because these stories, I think, help remind us of what the work really means and just how valuable this kind of care is. So here's the story of Pat, as told to us by her daughter, Ginny.
She was very fortunate to have another 8 years from the time of her diagnosis that she was able to enjoy life, go on trips with us, enjoy the family and the great-grandchildren, and continue with her knitting and needlepoint. And she had written a book about her time as a child in Hana with Georgia O'Keeffe. And so she was actually going around the state and giving book signings and talking about her books. So her last years were just a wonderful opportunity that she had this extra time. She came into supportive care a couple of months ago when it was clear to me and to her physicians that this was recurrent cancer and that there really wasn't any additional treatment that wouldn't just make her more miserable, there was really nothing more, that this was end of life and that it was time to make her as comfortable as possible. She was not ready to accept that, even though her physicians and I knew, and I had talked with the rest of our family, so they were aware of that. But my mom wasn't ready to accept that it could be the end. She loved life, and she enjoyed every day, even though she was sometimes uncomfortable. She would rally to the occasion. She just loved being with family and friends and doing the things that she liked to do. So she didn't want to acknowledge that it was a time to accept that there's a time when we all have to pass on. The whole family then met with the nurse and the social worker and the other supportive team members, and they were just wonderful. They'd come and sit in the kitchen and we'd all be there, and my mom was part of the conversations, and she trusted, and the supportive team was just, they're so wonderful. They're so experienced, they're so kind and understanding, and they just know how to help people get the extra help that they need to be comfortable. And they just did an outstanding job. And my mom just came to enjoy them so much. She just couldn't say enough good things about the team. She could still see her medical oncologist, Dr. Okazaki, in Honolulu if she wanted. Nothing was being taken away from her. This was additional, wonderful supportive services brought to her in the home. And the beauty of it was, prior to the supportive team coming on board, she was constantly in the emergency room for one reason or another. And once they were on board, she did not have any more trips to the emergency room, because my brother, she lived in the house with my brother. He was able to be sort of a primary support system, but the hospice team would come and check on her on a regular basis so that she didn't need to go anywhere. It could all be brought to her. And that just made such a difference, because for anyone who's going through this with elderly parents, they know how difficult it is just to move a family member from the home to go to an office, to the hospital or to a clinic. It's just an all-day affair and it's miserable. So for her to be able to stay home and be doing her needlepoint or seeing her great-grandchildren, and then have a supportive team come to the house and take care of her and reassure my brother, who was anxious about, what am I going to do when something happens? And it was, call us anytime, 24 hours a day, 7 days a week. Here is my cell number. Somebody will answer the phone. That was very reassuring for my brother and the other family members who were there. It was all seamless. The supportive care team, the hospice team came in as part of this supportive care. And I don't know when it transitioned. My brother does, of course, because he was the one there every day. To me, it didn't make any difference. It was just this wonderful team taking care of her. She was always in charge. She never gave up control. That's right. It was important for her.
Thank you, Dr. Pressler. Thank you, Dr. Seitz. Appreciate your introduction. To say thank you so much, everyone, for joining us. I just did a quick survey looking at everyone, and I just can't believe your haircuts. I mean, I thought I was gonna have to wear a hat today, but you guys almost have like live-in hairdressers or something, because everybody looks fantastic. I'm actually gonna take the next few minutes really just to define our terms when we're talking about palliative care, share some national data and some standards as a way to set the stage for what I know is going to be a robust discussion for how we might all envision advancing palliative care across our islands. Now, the title for this talk, Living as Well as You Can for as Long as I Can, is borrowed from our colleague Steve Pantelat at UCSF. Steve was actually out here as a visiting professor at JAPSOM a couple of years ago, and he shared with us that this is actually his shorthand for defining palliative care for his patients. Ira Byock is a founder of U.S. palliative care. Rae already mentioned, that he's blessed us with his presence many times, and he was actually out here as a visiting professor just last year. This is the title of Ira's last book, The Best Care Possible. And I think, that phrase, the best care possible, is how many of us think about providing quality care for the seriously ill. But achieving quality is not always so straightforward. And even defining it isn't always so easy. And that's really why we've gathered you all here today, in case you were wondering. So the formal objectives for this short talk are defining palliative care and reviewing the minimum standards for palliative care. And you've already heard from Rae. These are things that we're going to come back to, revisit later in the morning. We really want your input on the chat box. The audio dropped out for me briefly, so I'm not sure if you heard, but we're going to be curating that chat box. So please comment as you go along, because everything is going to be curated and brought back for a robust discussion at the end of the day. And then I'm going to give you an extremely biased highlight of evidence for palliative care. So here we go. The Center to Advance Palliative Care has given us an evidence-based definition for palliative care. And I'm going to read it to you because they put a lot of effort into crafting this, and it really was market researched. It's over these 3 slides. Palliative care is specialized medical care for people living with serious illness. It focuses on providing patients with relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with a patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the prognosis, and we're going to return to that point again and again. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. And CAPC actually provides an elevator definition. They're in New York City, so they spend a lot of time in elevators. Palliative care is specialized medical care that treats the symptoms and stress of a serious illness. The goal is to improve quality of life. So that's our shorthand elevator definition of palliative care. Again, we're going to be coming back to the definition, so please think on that. That's why we sent it out to you by email yesterday. CAPC also provides us some palliative care minimum standards. A lot of people have spent time thinking about what minimum standards are. CMS has them, multiple states have made a stab at it, and we here today are going to be proposing our own minimum standards for palliative care in Hawaii. So take a look at these, and then we'll be revisiting this topic towards the end of the day. An interdisciplinary team is absolutely essential. If you're providing holistic care, you have to have a holistic team, including physician, nurse, social worker, chaplain, and others. At least one of these prescribers has to have certification in palliative care. Comprehensive assessment and management of a patient's symptoms are a core part of palliative care, and then communication on patient and family priorities for care. We call that our goals of care conversations, and advanced care planning is the way we operationalize that. And then meaningful and timely 24/7 response to crises, absolutely basic minimum standard for palliative care. Now, notice nothing I've said here is anything about end-of-life care, and that's really what we want to be messaging. Palliative care does not equal end-of-life care. The vast majority of patients seen by a palliative care program are not in their last days. They leave the hospital alive if they're in the hospital. Palliative care actually complements their life-prolonging therapies. It's introduced early during the course of the illness, and I'm going to show you data to show that makes a difference. The timing does make a difference. And again, based on need, not on prognosis. So I've got references here for you going back close to 30 years now. And it really is part of a growing and already robust evidence base that shows that palliative care reduces distressing symptoms, improves quality of life, increases family satisfaction, and multiple studies showing an association with prolongation of life. So this is my advanced care planning cartoon. I'll warn you that not all of my cartoons have anything to do with what I'm talking about. So that's an opportunity for you to comment in the chat box and opine on my sense of humor. Okay, Dave Cassaret, another friend of Hawaii, has been out here. When he was in Philadelphia at the VA there, he did an early study surveying family members of vets, over 500 families, and found that overall satisfaction, again, across multiple domains, was statistically superior among those that received palliative care. And this is one of the first studies that showed earlier is better. Earlier consultations were clearly better, associated with higher satisfaction among these families. The folks at MD Anderson actually have expanded on that work. They looked at nearly 400 cancer patients and again showed that better outcomes with earlier involvement of palliative care. These patients had fewer ER visits, fewer hospitalizations, and fewer hospital deaths if they got palliative care earlier. And these are not only statistically significant differences, they're actually clinically quite significant. They're all a robust reduction in some of these measures. So I warned you, not all of these have much to do with what I'm talking about. Again, this is a top opportunity to exercise in the chat box and opine. Okay, and I would lose my palliative care union card if I did not share this article with you. It really is a seminal article in palliative care 10 years ago in the New England Journal. Really the first high quality randomized controlled trial, 151 patients with newly diagnosed stage 4 lung cancer, randomized standard oncology care at the Massachusetts General Hospital versus that plus early palliative care, not waiting till people had refractory symptoms or had progressed through multiple lines of therapy to make a referral to palliative care, early referral to palliative care. Across multiple measures, the patients that got randomized to early palliative care had higher quality of life. Across multiple measures, they had lower ratings of depression and anxiety in the early palliative care group. And this is really the figure that rocked everyone's world. The patients that were randomized to early palliative care lived nearly 3 months longer than the patients that were not randomized to palliative care. I will remind you, this is the pre-immunotherapy era. This was approximately the survival benefit with platinum-based chemotherapy at that time. And that is why people said, if palliative care were a drug, the stockholders would be dancing in the streets when they saw this figure. That was a powerful, yes, we really knew by then that palliative care improved quality of life, improved family satisfaction, but this really got a lot of attention. And so this is one of the reasons that hospital-based palliative care, at least, has really grown tremendously. Now, approximately 80% of the hospitals of at least 50 beds in our nation do have a hospital-based palliative care team. But we're really here to talk so much more about community-based palliative care, and that's really where the challenge lies. Yes, we've had successes here in Hawaii and across the nation in getting hospital-based palliative care, but palliative care delivered in an office, in the home setting, in long-term care, post-acute care, or via telehealth, less of that here in Hawaii and across the nation. But you will be hearing about some amazing programs here in Hawaii that actually we are well ahead of many communities, but we don't want to be satisfied and rest on our laurels. We need to push on, because there are many people still not being served. This is one of the larger community-based palliative care programs on the mainland. It's Sharp Healthcare in California. They've published in JAGS 7 years of the patients. They looked at nearly 400 of their transitions patients. It's a community-based palliative care program. Patients with cancer, COPD, heart failure, or dementia, and they propensity matched them to patients that did not have the access to were not in the transitions program. The transitions program patients had less hospital use, lower hospital cost, less escalation of cost of care in the final 6 months. We know that there's that curve that costs typically escalate in the final 6 months of life, much less of that with the transitions patients, and then lower overall healthcare costs. And you can go to the chat box. Okay, I do want to take a couple of minutes to sort of contextualize the time and place we find ourselves in. There's a reason that we're all not, gathered together in one room, and that's obviously this terrible pandemic that we're dealing with. But also, our field has really been challenged and had opportunities with the opioid epidemic that we've also been living through the last few years. So I just wanted to take a couple slides to talk about those. I'd say the opioid epidemic, that really did pose challenges to us. It caused us to relook at the relationship of opioids and safety, and reassess how we balance safety and benefit from these drugs. And I'd say most programs have really done a reworking, and so that essentially all of our palliative care patients are getting the exact same kind of risk assessment and management as any chronic pain program. And that was kind of radical for us when we started doing that a few years back, doing informed consents, use agreements, routinely checking our prescription drug monitoring program. Urine drug screening. Oh my gosh, this patient has advanced cancer. We're going to make them pee in a cup? Yes, We do, because if we don't do it, if we only do it for the people that we're suspicious of, that's profiling. So it's universal. Rational polypharmacy. What kind of are we being really thoughtful about our co-analgesics or analgesic adjuvants, so that when we're using opioids, we're using the safest and most appropriate dose. Collaboration with our pharmacy and behavioral health colleagues to make sure we're adequately treating substance use disorder and other behavioral health diagnoses. And then yes, naloxone prescribing for patients at higher risk. I'd say for the COVID pandemic, I'll welcome your feedback in the chat box as well, but definitely there have been tremendous access issues. PPE has forced access issues for us, shortages. Facilities restricting visitors, keeping families apart. It's been really challenging. We're looking right now at what our policy should be in this, revisiting that, whether that can be changed, whether there's opportunities to soften that. And then, of course, this isolation has left people with fear and uncertainty, loneliness, and then guilt on the parts of family members when they cannot be there at the bedsides of their loved ones. I would say it's not all horrible news. If you want to be a glass half full person, I'd say we have seen a tremendous spotlight on advanced care planning placed on us because of the epidemic. Jeannette and I were actually just interviewed in the Kokua line in the Star Advertiser, just because they've been getting so many questions about advanced care planning because of the pandemic. And I would say I just cannot believe how rapidly telehealth has been adopted over the last few weeks. I mean, besides meetings like this, our physicians have been meeting across the state, but as we're reuniting patients and families and meeting with people, this is something that I think all of us believe is going to stay with us after the pandemic as a good thing, leveraging this technology. So I'm going to wrap up and remind you that palliative care focuses on relieving pain and suffering and promoting best possible quality of life. It can be considered for any serious illness, can be used at any time in the course of illness. It's person-centered and family inclusive, can be combined with curative treatments, and some studies have shown a survival advantage. It's more and more available to hospitalized patients across the country and in Hawaii. But the challenge really before us is the availability in the community. I want to finish with this quote from my mentor and former boss, Diane Meyer. She was interviewed in ACP Hospitalist last month, and she closed with, "It's not about prognosis, it's about need, it's about relief of suffering, and it's everybody's job." Well, I want to thank you very much for letting me set the stage there with the definitions and standards. And this time, we're going to move to a presentation from, would be Dr. Toby Smith, but unfortunately Dr. Smith cannot be with us. He had an urgency today. So my colleague, Dr. Rae Seitz, is going to return and talk to us about a program that's near and dear to many of us, HMSA's supportive care program. Rae.
Okay, thanks. So supportive care, next slide, please. This slide shows what the state of affairs were for people who died in Hawaii in 2012 and 2016 and compares it to the best in, or the average in the country. This is Dartmouth Atlas data, so it is Medicare beneficiary data. In 2012, you see that across all the metrics, we were pretty dismal. We were really at the bottom of the pile. Over the 4 years from 2012 to 2016, we did see some improvement, but we did not come anywhere close to the average in the country. Next slide, please. So I was at Kaiser for many years. I built home-based palliative care there. But I was really interested in being able to create a program that went across the state, because the Kaiser program was based only on Oahu. So I made the jump to HMSA, and we designed and stood up a program called supportive care. This program is, I think, combines the best of the core elements that I think are really important in any palliative care program. So first of all, again, the interdisciplinary team care. These teams came from the hospice organizations. And because hospice care and palliative care can be vastly different, we required that the physician on the team be the leader and that physician be certified in hospice and palliative medicine. And that is what we had. On the team also is nursing, either APRN or RN, social worker, and chaplain. These are the minimal standards that we felt needed to be present on the interdisciplinary team. And they had to be interdisciplinary, which meant they had to talk to each other and work together, not just do their own thing. Their goal was to do a comprehensive assessment. So physical, psychosocial, emotional, spiritual, that's why you need the whole team. Focus on good symptom management as well as care coordination. I came into palliative care from experience as a hospitalist. And I saw where the system completely failed our most vulnerable and complicated patients. And a lot of that was because there wasn't sufficient care coordination among all of the treating providers. And there wasn't coordination starting with what the patient himself or herself really wanted to pursue in terms of their goals of care. Communication was going to have to be a really important component of supportive care, which is in part why we chose to work with our hospice partners, because they are very good at listening to people, at eliciting goals of care, assessing caregiver needs, etc. We also required 24/7 availability. And again, the hospices already had that in place. We set admission criteria and we set a 90-day limit on service. And we can talk about why that is later. Next slide. And we looked 4 months prior to their enrollment and 3 months after their enrollment. We saw a pretty startling steep curve, cost curve, which increased prior to coming in. But almost immediately after coming into supportive care, their costs declined. And these are facility costs. Just some background, over the years from 2013 to 2019, we had over 2,500 members enrolled in supportive care across all the islands. Many of them were our Medicare Advantage members, and the majority of them came from our commercial lines of business. There were a few Quest members who have received supportive care. When you look at the Quest, I wanted to highlight this because there's interest in developing a Quest benefit. We see that cancer is overwhelmingly the main diagnosis that people come into supportive care. And that is true across the other lines of business as well. There is a small number of people who come in with other diagnoses because we do allow exceptions to be made. So things like ALS, we've allowed those in on a case-by-case basis, a few children on a case-by-case basis. I think that this slide really drives home the point that Daniel made earlier, which is that palliative care is not limited to end-of-life care. And we see that in supportive care because about half of the population actually graduates. They get better and they go back to their usual medical care. About 25% of them transition to hospice care, and about 25% of them expire on the program. Again, for Quest, the numbers are fairly close, although more of the Quest members went back to usual care. This slide, when we grabbed this data, we were kind of astounded. 2013 was when we stood up supportive care. These are the rates of deaths in hospital of our Medicare Advantage supportive care members. The red line is best in class deaths in hospitals based on Dartmouth Atlas data. So you see that really at baseline, we were over 30% of our Medicare Advantage members who died were dying in the hospital. Within 4 months or so, 6 months, we saw a significant decline in deaths in hospital. It's not that we don't want people to die in the hospital on principle, but what we know from surveying many Americans is that most of them would prefer not to die in the hospital. And so if we're not paying attention to what our members really hope for, then we're possibly giving them unwanted care and causing avoidable suffering. But you see where supportive care was able to influence this metric, and that appeared to be a durable finding. So I want to go back to a slide that is similar to the initial slides of this particular presentation. Because when we looked at the outcomes for cancer patients, and now keep in mind that cancer patients really advanced cancer at the end of life, though that trajectory tends to be among the most predictable of trajectories of serious illness. So the percent of cancer patients dying in the hospital on average in Hawaii was 23%. Supportive care saw an improvement of this rate to 10%. ICU admissions in the last month of life, national average 30.2%, Hawaii a little bit better. Supportive care, much better. ICU days, many fewer ICU days for our supportive care cancer patients. And for those who are hospitalized in the last month of life, 30%. And for the hospitalizations, they spent about half the number of days in the hospital. So I think arguably
different problems.
We can say that palliative care really represents the best care possible. Not only is it affordable, we cannot afford not to provide this kind of care. Our healthcare system is going broke, and a lot of care that is really necessary, we're struggling to be able to provide overall for our community. And I do want to say that HMSA very strongly supports the further development and expansion of palliative care. It has identified palliative care and end-of-life care as one of the major focuses of their work in the next few years. Thank you.
Thank you so much, Rae. Thanks for jumping in to give us that presentation. You know, so many of us are big fans of supportive care program, and getting to see some of the data is really gratifying. Next, I want to welcome our good friend, Ms. Hope Young from Kokua, who's going to share a patient's story related to supportive care. Oh.
Thank you, Daniel. So this is my friend Johanna. We've known each other for over 30 years, and last year she announced that her cancer returned. So I tried to help her along and told her to ask for a palliative care consult, which she actually did. I asked her to share her story with us, and this is her story. My name is Johanna Kaupu. I have advanced stage 4 metastatic breast cancer. I was eligible for the 90-day palliative care support services, and I enrolled in Kaupu Care in December of 2019. My RN came to see me every Friday. I also had a social worker who was able to direct me to the Department of Human Services to obtain EBT and SNAP benefits for the months I was out of work. She was also my landlord. She also worked with my landlord and directed me to Hope Services, who helped pay for my rent. I did have a spiritual counselor who came by when I requested. I discharged myself from supportive care on January 31st, 2020, and was left with 53 days with the same team should I need to reach out to them in the near future. Due to my medical condition, I wanted to be sure that I saved as many days as possible, and my team agreed that it was a wise decision. They would be waiting and ready for my call. I would highly recommend palliative care services and support. My team was extremely easygoing, on top of every issue that worried and upset me, supportive on all levels, physically, socially, and psychologically, and went above and beyond to be sure that I knew they were only a phone call away. And it's true. I would pick up the phone to call my nurse regarding my side effects from the chemotherapy treatment I was on, and within an hour or less, I had medication waiting to be picked up at the pharmacy for nausea and dizziness. They helped me with pain management. They treated me as if I were a high priority patient. Mahalo nui loa.
Thank you, Hope. And now I want to welcome a good friend and colleague, Dr. Liane Tokushige from the VA, who's going to talk to us about their very exciting version of concurrent care, which to our understanding is really among the first in the nation for the VA. Liane, please.
Good morning, everyone. Thank you for asking us to join this Palliative Care Summit and to share our experiences at the VA. First, I'd like to introduce our team, which consists of Dr. Craig Chena, who developed our inpatient unit, which opened in 2009, and Amanda Wong, APRN, who coordinates our inpatient hospice admissions and concurrent care program, and myself. Our team is just 3 people. We do not provide the actual hands-on care, but we connect the interdisciplinary teams from the hospice community agencies with veterans who can use their support during their journey with advanced serious illness. Just wanted to share a few insights about VA in Hawaii. So Hawaii and Alaska are the only 2 states that do not have VA medical centers. So when you look up the hill to the Pink Hospital, that's Tripler Medical Center, and their mission is to ready our active duty troops to serve in combat. So veterans go there for care. They are considered retirees, and I don't get a report if they show up at the ER, even though I'm their VA PCP. So what happened to us was, in December 2017, we were listening to a national VA hospice and palliative care conference call, and we heard about this study that was published in Cancer in 2016 that was entitled "The Rise of Concurrent Care for Veterans with Advanced Cancer at the End of Life." It was a retrospective cohort study using VA and Medicare administrative data. So their definition of concurrent care was someone who they identified using Medicare billing for hospice services and VA data for receiving chemotherapy and radiation therapy. So although it was a national study, Hawaii wasn't really part of it because we didn't have a medical center and we don't have oncologists and radiation therapists and PET scanners. So our Hawaii veterans come to the VA already using their Medicare for oncological care, and they want to know what else the VA can do to help them. So we wanted our Hawaii veterans to have access to what their counterparts on the continental US had, so we created an actual program, because the rest of the United States is just, it's not really a program. And we were very fortunate to build on what HMSA and UHA had already started. So this is our eligibility criteria. They have to be registered and eligible for VA care. They have to have a hospice diagnosis and a life expectancy of less than 6 months. Potential admission diagnoses are cancer stage 4 with the oncologist designating that they're hospice appropriate, or advanced heart disease, pulmonary disease, liver disease, and other conditions could be approved. Next slide. How do you get concurrent care here? They need to be seen by actually our palliative care team. And if they are eligible, then the team will initiate the authorization process and contact the community agency that the veteran chooses. So these are the 2 main numbers. The VA main number is 1-800-214-1306, option 2. And it's actually, even though it's 1-800, it's a Hawaii person answers. And then if that's not successful, then you can also contact us at 433-7676. So this is a summary. The VA way, or the mainland way, is Medicare is paying for the home support, and then the VA is doing the disease treatments. And then this is our way in Hawaii, where we're paying for the home support, and Medicare or private insurance is often paying for the disease treatments. But if they have no other insurance, then the VA is paying for both. And then this is just a summary of the difference between hospice care and VA concurrent care. So of course the comfort treatments are offered by both, but as far as disease treatments and whether it's okay to go to the hospital, it would just be available if they're on concurrent care. This is one of our first patients. He was a 76-year-old man, Vietnam veteran, exposed to Agent Orange with COPD, and he was in the hospital for 3 months. They tried to get him to sign up for traditional hospice and he refused because when he was short of breath, he wanted to be able to go to the ER. Fortunately, it was about the same time we were rolling out our program, and so he was able to go home. So we did the consult, and then he was able to go home for 68 days before he died at home. He never ended up going to the hospital or ER. So this is just some cost estimates where I assumed that the cost before concurrent care was 90 days times $5,000 a day, which is probably a lot more than that. That's how I came up with these numbers. The 450 cost of concurrent care was 68 days times 160 a day. He never went to the hospital, and so this was our estimated cost savings. And I used this to convince the VA to think about supporting this. And this is why I get up every morning and go to work. This is what the wife said after her husband had passed away. This program was tremendous. My husband wasn't ready for hospice because if he chose hospice, it's like saying I'm dead. So while in the hospital, everyone was trying to convince him to choose traditional hospice. However, this program gave him another option and he was able to go home. It was the best. We were very pleased and he was happy he got to go home and still had hope that he could call the ambulance if needed. The hospice nurse was very caring and they lifted his spirits. And that's my story. Thank you.
Thank you so much, Liane. I loved hearing that great presentation. And now we're going to turn to another wonderful friend and colleague of ours, Dr. Ritabelle Fernandes from Bristol Hospice, who's going to talk about their Ohana pilot.
Aloha, everyone. Thank you to the Supportive Care Pilot. I would like to begin by thanking my mentors, Dr. Fess and Dr. Dongmei Lee, for their assistance with the data analysis and the graphs that you are about to see. So I would like to give a special thanks to Ohana Health Plan, WellCare Inc., for their transparency in sharing their cost data, for their willingness to take on this challenge of helping their super utilizers. I would like to thank the Ohana members who participated in this pilot. And I'd also like to thank the Journal of Palliative Medicine who has agreed to publish our manuscript. Let's look at this population pyramid. And when we are talking about the super utilizers, we are talking about the members right at the top of this population pyramid. They have multiple chronic conditions, they're frail, elderly, low income, low health literacy, a lot of psychosocial issues. The social determinants of health play a big role. And health plans have struggled with this group and tried many interventions like case management, community health workers, navigators, telehealth. So many options have been tried for this particular group. And Ohana was willing to try supportive care as an option to members of this group. So what were the criteria to be part of this pilot? The members had to have an advanced chronic illness and 3 hospitalizations in the past year, or at least 1 prolonged hospital stay defined as more than 30 days, or they had to be overall costs top 1% of the healthcare costs in the prior calendar year. Now, persons who were excluded were serious mental illness, pediatric population, nursing home patients, those who are already on hospice, members living on a neighbor island, because this was with Bristol Hospice and we only served the island of Oahu. The source of the referrals was the Service Coordination Department. So this is a flow chart showing you what I mentioned. They screened 10,000 members and majority did not meet the inclusion criteria. It came down to 52 superutilizers, but many were excluded for mental illness or hospice or pediatric population. And we were referred in the end 27 members. And of those 27 members, 21 enrolled in the pilot. Now this is interesting because that's a 77% enrollment rate, which is very high for this particular group of members. So let's look at the intervention. What did we do? From a period of August 2017 to 2018, over a year, we had a rolling enrollment. 27 members were referred to us. We enrolled 21 of them. We delivered interdisciplinary hospice-like services, so they got the full team. A key feature was care coordination with the PCP, with the specialists, and the service coordinators were kept in the loop every step of the way. The duration of services for this pilot was 90 days, but they're open to looking at prior authorizations and extending the 90 days beyond the pilot. Another key feature was the 24/7 triage availability via phone or in person by an RN. And the rate of reimbursement for this pilot was the routine home hospice rate. So let's look at the demographics of these 21 members. We had 10 male and 11 female. We had 10 members had Medicare, while all of them had Medicaid. So majority were Medicaid, but half did have Medicare and Medicaid. As far as ethnicities, majority were Hawaiian, 8 were Hawaiian, followed by 4 Samoan, 4 other Pacific Islanders like Chukis, Marshallese. We had 4 Asians and 1 other. In the age distribution, you will see that 6 members were under the age of 55. The youngest member was 31 years old. Then there was still quite a few in the group of 55 to 64. Let's look at the diagnosis. So the diagnosis, top condition was hypertension, diabetes, cardiac-related conditions. Second to cardiac was infections. They are having a lot of hospitalizations for people with, say, a stage 4 coccyx or stump infection, amputation infections, gangrenes. So infection really ranks second, followed by pulmonary, then oncology. If we look at the palliative performance scale, most of these members were homebound. 10, like more than half, were in the 40 to 50%. They're unable to work. They mostly sit and lie at home. So this was the PPS of these members. Moving on, I want you to understand we administered the Edmonton Symptom Assessment Scale. The nurse administered this at every visit. And so we're looking at changes in the ESAS over time. And you will see that from baseline to the end of the study, end of the 90 days, we were greatly able to improve the pain. It was clinically and statistically significant. We were able to improve the anxiety. We were able to improve the shortness of breath. There was a trend as far as depression was concerned. Regarding the other variables like well-being, we were unable to make any change on other items of the symptom assessment scale. Let's look at the utilization data, and this is shown by per member per month. So for these 21 members, the emergency room cost dropped by 73%. The inpatient cost dropped by 78%. What did increase? The pharmacy cost increased and the outpatient visit costs increased. And this is something we might expect because we were trying to get these members reconnected with their doctors and their specialists rather than thinking the ER doc is my PCP. No, we want you to get connected to your PCP, to your health centers. The pharmacy costs went up by 27%, and that's because members are now refilling their medication and taking their medication. Looking at the overall net savings was 36%. For those who are still drinking their morning coffee and yet to wake up, please pay attention to this. If only one slide, this slide. This is the money slide. We looked at the same data and looked at it per 1,000 members annualized. So what happens when you look at it per 1,000 members? The ED visit decreased by 79%. So before supportive care, it was 5,785 visits per 1,000 members, and this dropped to 1,188 per 1,000 members. The inpatient admission rate decreased by 75%. Before supportive care, it was 3,108 per 1,000 members, and after supportive care, it was 772 per 1,000 members. The overall net savings, even after paying Bristol Hospice for the routine care, was 36% to Johanna Health Plan. I would like to share with you a beautiful story, and this is how our team of social workers, chaplains, really got to what matters to the patient. Know me first, treat me next. So this young lady, we wanted to know what was really important to her because she was suffering from hemodialysis, and her diagnosis in the program was short gut syndrome. That's why we admitted her, short gut syndrome. After the 90 days, we transitioned her to hospice again under that diagnosis, short gut syndrome. But she would go to the ER at least twice a week, always going, continuously. But what really mattered to her was being reunited with her family, not in Samoa, but her sisters in Utah. So now this is a very complicated case. How do you get a Medicaid member from Hawaii to, we have to apply for Medicaid in Utah. We also have to connect with dialysis in Utah. We had to connect with hospice in Utah. And then she has no money for a plane ticket. And our team worked so hard, and we were blessed with the generous donation from the Dream Foundation. And here it is, she gets her certificate from the Dream Foundation, who bought her ticket. And this lady flew out on December 21st to join her sisters for Christmas of December 2017. A very beautiful story, and happened by the grace of God. So I conclude that supportive care has the potential to be a clinically, emotionally, and financially beneficial solution in treating costly and complex superutilizers in managed care organizations. Thank you.
Thank you very much, Ritabelle. And now we want to turn to another friend and a pioneer of palliative care here in Hawaii, Brenda Ho, who's the CEO of Hawaii Care Choices, beaming into us from the Big Island. Brenda, welcome.
Aloha, everyone, and thank you, Dr. Fischberg, doing a great job. So I have 5 minutes. I'm going to run through this extremely fast. So the first slide is just telling us that currently our name is Hawaii Care Choices, which was a new name, our name changed in 2018. But our goal is to improve the lives of those we touch. We have lots of partnerships in our exploration of palliative care in East Hawaii, and this is just a few of them. You know, as you've all heard, and it's been explained extremely well, palliative care is the support that focuses on relieving pain and discomfort from serious illness and treatments, just that suffering that happens to many of our folks. Our pilot, our product is called Kaupu Care. We chose that because folks were confused about palliative care. But our program, Kaupu Care, for the community-based, started in April of 2016. And so it's been in 4 years. In that time frame, we've served 248 patients. Now, the importance of this is that we started our program through grant funding, And as the funding started running out and we were not as successful as we had hoped at getting the health plans on board for this program, again, this is pre-Kaupu or pre-supportive care, just to add a little confusion for you folks. But we had 248 patients, and in that time frame, we were able to do the program without charging the patients. It was community-based, so we went to where the patients were. We would meet them at their doctor's office or in their homes, wherever it best needed for the patient. And again, we were looking at palliative care symptom management and care coordination. Just to kind of give you a picture, one of the things that we really found is the complexity of our patients. Much like what you've heard from the other programs, the majority of our patients that we've served in those 4 years have been cancer. We have, the next one was circulatory or heart disease, because we really were focused on congestive heart failure and symptoms around that, and then respiratory disease. You could see some of our patients were discharged with one, so we served 248, but you see 263 there. It's because we readmitted patients, sometimes with different diagnoses, depending on what was causing them the most issues at that time. One of the things that we found in our patient population, which was also mentioned, is the complexity of our patients. And part of that was because of their multiple needs, their comorbidities, their self-care. And we did take care of and included people with mental health issues or substance abuse. And so juggling all of that and taking care of these really high need patients was quite a challenge, and still is to this day. We have a significant number of social determinants of health here on the Big Island, especially the east side. So that was even demonstrated in the Hawaii Health Matters, the Hawaii County study that was done. We have a disproportionate healthcare and socioeconomic complexities. Another thing that's interesting about the east side of the island is we have on the Hawaii County, we have a really high percent of our individuals, our population, are seniors, which is a population that frequently needs this additional support. So we're about 21%. The Kaupu Care Industry team is a registered nurse, the social worker, nurse practitioners, spiritual counselors, really trying to embrace the family. So Kaupu Care, you can see our insurance, the next slide. Payers, thank you very much for United Health Care being partnered with us since January. We hope to get some new studies out, and University Health Alliance has been a key partner with this type of care, and HMSA supportive care program as well. Thank you, that's all.
Brenda, thank you so much. I'm blown away that, how is it coming from a distance over there? You have the best image and the best audio of any presenter, so thanks so much. Now we're gonna kick it back over to Rae, who has another patient experience that she's gonna share with us.
Okay, this is Dr. Salvador, who is a 77-year-old physician. He came into supportive care when he was diagnosed with cancer of the mandible and had undergone surgery and radiation therapy. And as you can imagine, his symptom burden was fairly high. He couldn't eat. He felt very weak. His mind was described by him as being, quote, slow. His PCP suggested that he enroll in supportive care, and he was on the service for a full 90 days before he graduated back to usual care. He tells me that his RN visited twice a week, his social worker once a month, but he also had visits from a dietitian and from physical therapy. To him, the highest value of this program was the pain and symptom management that he received. He felt it was highly effective. But the other thing that was really important to him was the social support that he received. You see, this guy has no family here. He lives alone. Without supportive care, he was faced with having to obtain food and medication and get to his various appointments all on his own. So the support that he received from the interdisciplinary team, he felt really helped him stay out of the depths of depression and hopelessness. He feels very deeply that without this program, he would have died. That's a sentiment that actually has been expressed to me directly from a number of patients.
That's great, Rae. I mean, and we've seen the data, the controlled data showing life prolongation, but an anecdote like that really hits it home that the patient themselves feels their life was saved by that program. I'm going to now
just add something because I saw that there were some chats about how long do people live, and we don't have that data from supportive care, but he's a guy who is now back to living independently. He can get things on his own. He's exercising out of the house, etc. So his functional status is almost normal.
Great. Thank you, Rae. Okay, and now I'm going to toss over to Jeannette Koijane from Kokua, who's going to do a presentation with me about some local data that we've been gathering over the last few months. And many of you, I'm sure, participate in some of these surveys. So, Jeannette.
Thank you very much, Rae, for that great story that illustrates what it is we're trying to do. So I'm going to present briefly some of the research that we collected here in Hawaii in preparation for this summit to find out what is going on in our community. So we conducted some focus groups and also some surveys, and I'm going to present that data briefly here. So we had a number of focus groups, very lively groups, the hospices, MedQuest directors, chaplains, home health, and then a mixture of various disciplines at a Kokua Mau meeting. We asked people 4 questions. Do you agree with the CAPC definition of palliative care? What's working, what's missing, the barriers, and what are opportunities for moving forward? So first of all, people really liked the CAPC definition. They thought this was a great way to define a benefit. A couple of interesting comments were, let's include the CMS definition as well. If we're trying to get the CMS to approve this benefit, that might be good to improve. And then the comment was made to include both spiritual care and social work in a definition. So as you see, definitions were really important. Overall, so then we move into what did people like about palliative care. So overall, people were very enthusiastic about palliative care. Palliative care is the way care is supposed to be, looking at the whole person. So people felt that the team approach was important and a great way to help with the complex medical issues that people have, having good conversations, getting the patient and family on the same page. Coordination of care, recognizing patient and family needs was mentioned often, which included medication reconciliation, pain and symptom management, spiritual support, also the rapport and trust that's built through these conversations, and then the training for the staff that this is palliative care is an excellent way to train the staff. So people were very enthusiastic about the thought that there would be a palliative care quest benefit and that this would really be helping people in an outpatient setting. So then the question is, what's missing? And so one of the things that came up over and over again is we need more community-based options and that all the health plans should offer palliative care. There were a number of stories where people said, oh, it was so disappointing that there was a patient who needed the outpatient palliative care, but they didn't have the right insurance. People emphasized the importance of starting early with conversations and planning. And you've heard that theme today. And then a number of times it came up to clearly define what a palliative care benefit would provide. What are the core elements? What's the definition? And what's the difference with hospice? So again, what this actual definitions are is something that came up. Educate what palliative care really is. It's not death care, it's not hospice, it's a very important part of the continuum of care. I included this comment because I thought it was very important for us to remember that clinicians and physicians lack the time, but they often lack the time, often lack the ability to communicate well. So how do we educate people on communication? And then oftentimes people talked about the importance of the entire team, doctor, nurse, social worker, and the chaplain, and that the reimbursement should reflect that.
And yes, we had a focus group with chaplains, but it did come up also with other groups about the importance of spiritual care and that this piece was often missing. So we also compiled the feedback on supportive care because that is really the biggest in-home palliative care program that we have. Shout out to UHA for their concurrent care benefit, and HMSA really is, as we know, the largest insurer in the state. So first of all, want to start out that there is really widespread enthusiasm for supportive care. People really like supportive care. But there are suggestions on how to improve. The first thing was that people wanted support for patients after the 90 days, and they're finding that people are saving their days. So you heard that with Johanna, that people are saving. She said the same thing. So people are delaying joining the program, and they also go off of the program sometimes when it's not medically advisable with this idea that they want to save their days. Another comment that came up was the need to start the process earlier, that oftentimes by the time the patients get into supportive care, they really have this need for intense management. They have very complicated situation going on, and they don't get the full team benefit of supportive care. So patients need support throughout the continuum of care, and that what is it that can be happening with patients earlier in the process. There was the suggestion to include more than 3 diagnoses. And then it was very clear that this is a great opportunity right now to improve the communication, quality management, and oversight with HMSA providers and the patients. Again, people love the benefit and they have suggestions on how to make it even stronger. So the last part of our focus groups, we're looking to what is it that we can be doing to expand. And the first one I'm putting under the heading of payment reform. So people were very enthusiastic about the fact that MedQuest is aspiring to have this palliative care benefit. There was a lot of support for that. A lot of support for the program Liane talked about at the VA, that is very important as well. People have been hearing about the Johanna and the United pilots, so expanding that was good. Medicare Advantage, HMSA is offering it. Wouldn't it be great if other health plans were able to offer it? Another comment that came up often was, what about palliative care in long-term care? That would be very needed. And then I put in this last one as a suggestion of some of the great suggestions that came up, that, palliative care and oncology fit together so nicely. A lot of oncology patients are in palliative care. What about some sort of a pilot to be looking to see how to boost palliative care with oncology? The next category was ways to increase and strengthen the workforce. So how are we going to expand the palliative care specialist workforce? So those are physicians, nurses, social workers, and chaplains who are trained specifically in palliative care, and also those other clinicians who need primary palliative care skills. Super important. A theme that comes up over and over again was education, and how important education is to help people understand what it is exactly that palliative care is. So how do we educate families, the public, patients? Also, how are we educating referral sources? All of the hospices said they were very able and willing to take more patients, but they needed the referral sources on board, PCPs, specialists, case managers. And I did want to, a number of people mentioned, and we're very happy that the Department of Health has invited Kokua to expand education on palliative care, and we're collaborating with them. And then the last piece that was talked about was under the heading of quality data research. And again, we're talking a lot about it today. We need to define what palliative care is, what's the definition and the core elements. I think, and a number of people talked about how important it would be for us as a community to define what are the measures, what are the data points that we're going to be looking at, and then monitoring the progress there. And then mapping palliative care in Hawaii. Where is it available? What's going on? And on this last point, we are very fortunate to have a grad student, Chelsea Hirano, who is with the UH nursing program, who's been helping us to pull together what's available where. And again, we have a lot more data that we just don't have time to share today. Inpatient, there are a number of programs that have palliative care teams, including on the neighbor islands, both on Maui and at Wilcox on Kauai. And then we've been talking about the community-based programs through UHA with the concurrent care, HMSA and supportive care, the new VA concurrent care program, and the pediatric concurrent care hospice benefit. There are two programs that are outpatient that are have elements of palliative care and have palliative care medical specialists that work on them. Queen's Supportive Oncology and the Straub Geriatric and Palliative Care Clinic. And then several hospices have really been very creative and innovative of standing up programs that help patients and their families. These programs have elements of palliative care, super welcome, and they're really important to have them, but they're not palliative care under the robust discussion that we are talking about. So the next short study I'm going to talk about was a survey that we did with case managers. There were 30 case managers who were, vast majority of them were nurses. Most commonly, they were referring to supportive care. And the most common reasons that they were referring to supportive care were pain and symptom management, hospice discussion or referral, patient and family support, and then the psychosocial and spiritual support. That's why people were utilizing the service. And then the other thing was, again, people were very enthusiastic about this and had suggestions about how are we going to move forward. We mentioned some of these from the focus groups, the education. People don't know what palliative care is. Better communication between health plans, hospices, providers. Better coordination when a member comes off of supportive care and returns to usual care. What happens then? That was seen as a gap. Certainly, people wanted to have these programs available across the islands. And then it was important to look and see measuring what matters and looking at quality data. So very quick overview, but some themes are certainly reoccurring. And now Dr. Fischberg is going to jump in and do our last local survey.
Thanks, Jeannette. So we did do a provider survey that perhaps many of you participated in. We ran it over through March and April. Got 63 respondents, and we sent it out. This is not a scientific study. It was not, randomized, but we sent it out through the American College of Physicians local chapter, the Hawaii Clinical Oncology, departments of family medicine, departments of geriatric medicine, and then basically, who did you know? So not science, but just really wanted to know what people were thinking out there. Of our respondents, about 80% were physicians and 16% identified as nurses or advanced practice nurses. Of the physicians, just over half identified as a subspecialty and just over a third as primary care. There were some researchers and administrative people in there, and a majority identified as office-based among the providers, with a quarter being hospital-based. And we asked them whether they'd had a patient in the last year that they had wanted to refer for community-based palliative care. And overwhelmingly, 93% said they did in fact have somebody to refer. We asked about their experiences with making these referrals and the outcomes of the referrals, and generally there were very high satisfaction rates in terms of rating the palliative care, community palliative care as effective. Actually, not just community, but hospital-based too. We asked them in the hospital in different settings tended to be satisfied, and about 3/4 said yes, that the families and the patients are always or often satisfied with the palliative care to which they refer them. Although not surprisingly, very relevant to our discussion today, 86% said that they do encounter barriers to referral, and that was either always, sometimes, or often. So those barriers are out there, and I don't think that's earth-shattering news to any one of us. When we asked people where they were encountering the barriers, clearly it was much more in the community than the hospital, and that's really where we started today, right? We said hospital-based palliative care has grown quite a bit, both in our community and in the nation, but it is in the community where we have lots of work to do. And then we asked what were the top barriers, and people were saying wrong insurance, maybe they didn't know who to call, and then reluctance. And that reluctance came in a couple of flavors. They felt that the patient and family were reluctant to accept a referral for a community-based palliative care program. When we asked what were the reasons people refer to community-based palliative care, pretty much 50 to 60%, these are fairly well represented. Patient or family support, hospice discussion or referral, in fact, pain management, other symptom management, and psychosocial support. Then we asked them, if we're thinking about creating these benefits in our community, what do you think should be core elements that you would want included in a community-based palliative care benefit? And you can see the numbers, 80% and up. Patient and family support, again, right at the top. Help with these goals of care discussions and psychosocial support, but pain management, other symptom management, and again, advanced care planning, all receiving a lot of enthusiasm to be a core element in any palliative care. Okay, so this is time to wake up. You've seen some beautifully coiffed heads and brilliant talking heads today. You can move this poll out of the way so you can read this definition. Grab it with your cursor near the top. I'm moving it now. But this is the definition, the CAPC definition that I shared with you this morning. I am not going to inflict reading it upon you a second time. You can read it yourself. And again, if you need to move the poll, just move it, but please do. We want to know, do you agree wholeheartedly with this definition? Do you agree but have some additional thoughts? And if you do, please comment in the chat section. We're getting to the point where we're going to be going through your thoughts and what you shared. And then if you don't agree, tell us what you think. Okay, so let's vote. Got to press submit. Don't be like me and forget to press submit. So we're going to have more discussion on this later, but just for those, I'm sorry for those of you who couldn't participate, but close to 80% said yes, they agree. 20% said they agree, and they have some other thoughts. And I'm very interested to hear what those thoughts are. Put those in the chat box, okay? Because we're going to be coming back and we are curating those. We're going to move on to another poll now. Now we're going to talk about the minimum standards. I've told you that there are many different, again, you can move the box so you can read these because these are a little bit different from what you've seen before. We've talked about, so I am going to read these to you. This is very similar to the CAPC minimum standards, but we have crafted our own for Hawaii. It includes comprehensive assessment, and we stipulate that includes the physical, emotional, psychosocial, spiritual, functional, and caregiver needs, all as essential domains for that comprehensive assessment. And that leads to the development of an individualized care plan. Related to care coordination and communication, that's collaboration, education, and understanding what matters most to the patient and family, and advanced care planning is a way to operationalize that. And then our clinical services, we agree, it should be interdisciplinary, specialist trained and certified, and have that 24/7 availability. And I've been talking so long, I did not get to vote. So vote whether you say the standards are adequate, you think something's missing, put it in the chat box, or something should not be a standard, and tell us about that too. And then don't be like me, don't forget to press submit.
Another 20 seconds for the poll. We're at 65%.
All right, we're getting better. There's a learning curve here.
All right, closing the poll.
All right, so 90% essentially felt like those standards. 7% said that they had something missing, and 4% thought there's something in there that should be removed. So we'll be curating that and discussing that. It's nice to have something to, good thing we saved some time at the end for discussion because we have something to talk about. So now we're going to move on to our next poll. I think we have one more if I can count to 3. All right, so CAPC has identified, these different areas to move palliative care forward. And that's specialty workforce development, payment reform, clinical skills development, research quality data, and public and clinician education, which I would say is a big part of awareness. You can read the more details about that. And we would like you to select 3 that you think should be what we as a group should be dedicating ourselves. So this is not a single one, but you pick 3. I'm doing it now.
All right, 25%, 40%, 70%.
Okay, I think we're doing well. We can take a couple more seconds to let everyone vote because there's a lot on this one.
All right, another 5 seconds. Closing the poll.
Now this is interesting. So it looks like the number 1 was public and clinician education. That was the sort of awareness piece. followed closely by payment reform, then clinical skills development, specialty workforce development, and the last is research quality and data. Okay, well, thank you very much for participating in that. And now we're going to toss over to Drs. Buenconsejo-Lum and Takeshi Uemura, who are going to talk to us a little bit about what you guys have been chatting about while we've been talking at you.
Okay, hi everyone. So yeah, thank you for all of the great comments, the chat box, and a lot of kudos in there and a lot of good other things. So just to let you know, what you're viewing now is a Jamboard that allows everyone to, it's like the sticky notes if we were doing this in person. And so again, we have the full chat comments, but so that we have space on this and so that you can see it, I'm abbreviating it here, and Takeshi's helping copy and paste certain things.
I'm doing my best.
Yeah, so for the definitions, you know, what we heard some kind of themes is that the CMS definitions and the benefit approval language are important. It also makes it more holistic. There was a lot of comment about explicitly stating social work and chaplaincy, and then, you know, make sure that there's comfort-directed medical care and include family support, you know, include peds in the definitions, et cetera. And there's more, but we're gonna, just for the sake of time, you know, we're gonna not put every single chat into this Jamboard, but again, we are capturing it. There's also a separate Word file that you're not seeing, that we've been recording it. In terms of the minimum standards, some of the, and then again, related to this, is you know, the fact that depending on certain specialty training, it may not be available in Hawaii, and so that has implications for you know, workforce needs. In terms of some of the priorities that have come out, these are the groups in blue, and came really from a kind of a summary of what Jeannette and Daniel, you know, presented. So again, it's not really encompassing everything, but from early on, you know, kind of identifying the barriers, and you can see which one I'm on because my name has a little clicky, you know, you can see me in pink there on the screen. But certainly, you know, one thing is we do have existing resources, but we know that there's a lot of barriers that are not letting those resources be fully utilized. And we've also heard, of course, could be education. There's a lot of fear. There's a lot of uncertainty. And then on the PED side, you know, given the nature of pediatric cancers and the current model doesn't really fit. There's a lot of barriers to the 90 days, psychological barriers, et cetera, that the parents face. And so really, if we're going to look at an outpatient palliative care model, we need to have one that doesn't really have time limits. And I think that also came out in a lot of the conversations is what about if they need more than 90 days, et cetera. Palliative care also, besides outpatient settings, should be provided in long-term care settings. And then now I'm hearing an echo, so I'm not sure why, because it's not me. But anyway, we need one strategy to consider is more collaboration with the oncology community. A lot of comments about, again, reimbursement that ties in with these definitions in terms of making sure the chaplaincy services and all services provided by the team are reimbursed. And then, of course, the education and starting the conversations earlier, those are all kind of grouped together. And then probably the biggest one is that all health plans should offer palliative care and the pilot should be expanded. And so, and there's other comments about neurologists, so not just the oncologists, and we do have one nephrologist, Dr. Sugihara, who's on the call, but certainly nephrologists, you know, may be a good ally here besides the oncologists. And so, Crystal, if you could move to the next frame. Then we have some questions, and most of them have been answered, but there's a couple of kind of parking lot questions. So here on the left side, there's early definitions of stress or distress, and I think that's been clarified several times now throughout the discussion that this was a CAPC definition, which uses the word stress, although clearly there is a lot of distress. But again, we're trying to use the CAPC definition. Then there were some, question about the for the palliative care patients, are there actually any quantitative data for mental health needs and for treated and untreated mental health? And that was because of I think a statement made on one of the earlier slides. And is that conjecture or is there actual data? So again, not a question necessarily to be answered here, but just something to consider because there's a lot of comments about quantifying this. And so, if you're looking at outcomes, right, then capturing mental health information would probably be a very good outcome. Because we know from all the studies that Daniel presented and that Ritabelle presented that there indeed are many outcomes related to depression, anxiety. The blue column here are some questions related to the HMSA slides. And so over the course of the presentation, it was defined, of course, that going back to usual care means that the supportive care was withdrawn. And that really led us to so many comments about this needs to expand beyond 90 days or have more flexibility. There was some question about, do we have any more recent data about the supportive care since it became a benefit standard? Rae answered a question saying that there actually is not any data on how long patients live once they use their 90-day benefit. And this really came because we know that many of patients are actually hospice eligible, but not yet emotionally ready. So that might be a consideration for future data. And then just again, kind of more questions related to the original HMSA data. So we're going to turn now for Bristol. I think a lot of comments that was an excellent presentation, and thanking Ritabelle and many others. And so the question was, did the Bristol Johanna study have a matched cohort? And it was no, this is a prospective study. And then again, the cost comparisons were just made for pre, during, and post. And so, I think there's also some comments that it was like, wow, okay, if there's this study, then perhaps we should consider using similar types of measures, for going forward for any kind of quantification of these efforts. And then some other comments that may be an action plan, which I actually have on another page, but it's just clarity on which current hospices, for other current hospices, which actually have palliative care, supportive care, and traditional care. So this means a dashboard to me, and that's what I put on the other slide, which you'll see next. And then just some question about the provider survey, just to see again neighbor islands and other things, and there is some breakdown, but for for time purposes, we didn't want to, we're really just trying to capture the biggest points. But yes, there is a more detailed breakdown. And then another question, again, this is something to be considered. Maybe, as there's been a lot of comments about reimbursement and insurance and other things, is what about, death doulas or other things? Then some other comments. So first, kudos to the Hawaii VA team because they do advocate for pediatric dependents of veterans so that the pediatric patients can receive concurrent care. Looks like Kaiser has some great work on population-based outpatient care, and that could be very useful to help with current and then future analysis. And again, another data kind of comment that, we need more data, we need more sharing data, and we understand that everybody has different levels of privacy and proprietary concerns. But really, if we're going to be able to do this as a state, we really need to have some agreed upon indicators and data that all the health plans and others would be willing to share. And then a comment again about that the nephrologists, in addition to oncologists, may be willing to help. And then if we can go to the action items, then just these are, again, not all of it. And I know I just talked to you really quickly, but I just want to make sure that we have time to add to this. but clearly there are a lot of barriers, again, that we need to identify. And to me, this really ties in with the education, which we saw from the poll was kind of our top leading choice. And so, to build an educational program, you do have to kind of identify barriers. And again, the point here is that there's a lot of great pilot programs or actually now, actual benefits, but there's still a lot of people that aren't referring. And then, just a reminder, of course, from our pediatric colleagues is that we need to make sure that pediatrics is included in whatever is built, and in particular, outpatient palliative care for peds. A lot of concurrence, I think, about expanding the current criteria and diagnoses to include non-cancer diagnoses. Personally, I would add, end-stage COPD to this list as well. I talked about the dashboard. We talked about the big focus. And then, and then just some other comments from the chat from the PCP communities. Again, it's a lot of, and this gets back to the definition and standards. And so we know this as PCPs with telehealth, there may be kind of standards or guidance from CMS or whatever, but locally, how we implement it is really different. How the different health plans implement it is different. And so that causes a lot of confusion among the PCPs, what are the referral criteria, but then also how do you do it? Again, who is able to support this? So again, the dashboard concept I think would be useful here. And then again, the definitions we talked about, and just a lot of clarity. And so but really I think all of the comments that you folks have put into the chat is good. And then I'm actually going to include one additional comment here from Dr. Nakatsuka, is that the divide between hospital and community-based is actually really artificial. And so therefore the definition, it should be really clear that it includes both. And then the implication is that, when you're defining then a benefit, that again, there's really clear distinction. And so I'll stop there so that we still have time for additional discussion. Thanks. And thank you to Dr. Uemura for helping capture all of this information.
Thank you, Lee.
Thank you, Liane Tokushige. That was very well done, a very rich discussion that you've collated there from the chat area. I want to add, if your comments somehow did not find their way onto the chat board, or if you were entering things as Lee was speaking, please continue, enter things into the chat board, because we're going to curate all this and keep this for future feedback. I was also gratified to see that people are already starting to volunteer for aspects of the things they'd like to work with us on, and that is so gratifying. That is our big ask here today, to identify which of these things you want to be working on. I certainly heard a big theme there, Lee, that a lot of people have enthusiasm for the concurrent care, supportive care programs that are out there, and that we basically just need more of them, more diagnoses, more payers adopting those things. I was wondering, I did hear a lot of discussion there about the definitions. And Jeannette, I'm wondering if I might toss to you. I think you've spent more hours reading definitions of palliative care across the nation than anybody I know. I want to ask you specifically, does the CAPC definition give short shrift to the non-physician, non-nurse members of the interdisciplinary team?
So as some background on the definition, what CAPC did was they did a nationwide survey trying to figure out how to best explain to people about what palliative care is. And that's where their definition, that definition is then also influenced. How do we get people to listen to us in terms of how great palliative care is? Their definition also comes from what it is people wanted to hear in order to sign up for palliative care. I don't think that it pays short shrift to anybody, but I can appreciate that some people would want, especially their discipline to be named. One of the important things about partnering with CAPC and using the CAPC definition is that they have a whole bunch of other supportive materials that will help us to talk about palliative care. It's important to say the definition helps to build a benefit, what the elements of a benefit are, and then there's a number of talking points where we can be sure and talk about social workers and chaplains and the psychosocial support and all of that. So I think there's an interesting balance between having it too long, then nobody listens, and then you can't have everything in there. So I think these are really important and valuable steps at moving forward to this, so that we agree on what a palliative care benefit is, and then how do we talk about it, and how do we explain this to our community?
Thanks. I want to bring up the idea of minimum standards and core elements of a benefit. Interested in your thoughts on that, because I know you spend a lot of time thinking about that, and you can speak to it in any way you want. But there was one question that jumped out at me. Somebody asked what is meant by certified. When it says that one prescriber is certified, does that mean fellowship trained, or do you want to comment on anything related to the minimum standards?
I think that the way we applied certified for supportive care was we expected that the medical directors who were working on the supportive care teams were hospice and palliative medicine board certified. More recent times, I believe it was 2010, and Daniel, you can correct me if I'm wrong on that. The requirement for sitting for the boards was that there needed to be fellowship training. But prior to that, people coming into this work from internal medicine or pediatrics, anesthesia, what have you, could sit for the boards. But so I don't think we can, and there are many people who are board certified right now who did not do a fellowship in palliative care, but they're providing care, and I think they're included in those who are considered certified.
And of course, now we have a new hospice medical director board certification. There's also certification for nurses in palliative care, social workers as well.
Yeah, I think the point is that there used to be a time when you could hang out your shingle and call yourself a palliative care provider. We want to really move beyond that and set some standards for who exactly can call themselves a palliative care provider.
I am looking at the clock, and I am just also looking at the fact that we still have 103 participants with us, which is just amazing. And I think, Rae, you had messaged me, it's like, I think we're probably going to have to do this again sometime.
Soon.
Right?
Sometime soon. There are so many questions that, we can't get to. Just for supportive care alone, I was really gratified to see so many questions and ideas come out. Just a reminder to everybody that the virtual folder that you will have access to will have contact information. So if you have a specific question about supportive care, you don't know how to refer, what have you, Dr. Smith will be included in that list. If you have a question about Bristol, we've asked Dr. Fernandes to offer us the contact information, etc. So we're going to give you ways to get specific information that will help you do your work every day.
I'm going to try to wrap things up a little bit, but I will toss back to the panel for any final thoughts or comments, if that's okay. So we're winding down. It's been quite a 2 hours. And again, I really want to invite everybody to add comments in the chat box. You can keep doing that while I'm talking, but specifically, we want to know how you would like to join us in moving this work forward in Hawaii. Which of these areas, one or more, specialty workforce development, payment reform, clinical skills development, research quality and data, public and clinician education. And you don't have to vote for just one. So anyone that you would like to be contacted about, please let us know. We want to thank all of our speakers, all of our participants. I don't think I've ever been part of a conference where all the speakers were so wonderful about sticking to their time, even when we gave you such tight time frames. So thank you. Really want to thank our sponsors, Kokua, JAPSOM, Department of Health. I'd say by far the biggest thank you of the day goes to pretty much the hardest working, most skilled, most dedicated person I know, and that's Crystal Costa. She's a program specialist at JAPSOM. It's a total understatement to say that without Crystal, this summit would not have been at all possible. I think Rae and I would be on the beach, like throwing sand at each other. Crystal, on behalf of your colleagues on the planning committee, and I'm sure the entire audience, please accept our profound gratitude. And from across the islands, could we please give a round of applause? Okay, as you've heard, today's attendees will be receiving a brief post-event evaluation, and that will be another opportunity for you to express an interest in joining us and moving this work forward. You're also going to get a link with a folder to all of the presentations that you're also eager to look at, just seeing them once. I know it wasn't enough. You're going to get a link with all of the contact information for all these wonderful, well-coiffed people, so you can reach out to them and ask them questions, clarify what wasn't clear in their presentation. And finally, this summit is going to lead to the creation of a white paper on advancing palliative care in Hawaii, to which you will all be given access, and in fact, to which all you helped create with your participation today. So a deep thank you for all of that. You'll get access to that when it's completed. So this time I want to toss back to the panel for any closing thoughts or words of appreciation.
So I'm just going to toss out that we are hoping that the folks who want to continue on with this work and want to be on a task force or a working group on any of these topics, to put your name into the chat room to let us know, and we'll be pulling together teams. Anybody wants to work on data, education, health payment reform, please let us know. And it is our intention to meet again in 6 months, see where we're doing, and we're thinking that we can be working in the meantime. Obviously, we're in a different place than we thought we would be, but I also do need to thank all my amazing colleagues and all the effort, and the 107 people that called in this morning to participate. So thank you.
Yeah, I would like to say how amazing this summit has been today. We went through a lot of storming, norming, reforming, and for some of you know about those things. And yet all of us are standing together, and that's really gratifying. It was really, to have had the opportunity to not only look back, but take a look at what is going on today, every day, to help care for the people that I most care about in our community. I am totally gratified and awed and humbled by the work that you all are doing out there every day. So thank you so much for your partnership and for being here today.
Thank you very much, everybody. We'll see you next time.